Today I'm going to be talking about biologics and dermatology. And essentially what I'm going to be talking about is the use of biologics in psoriasis vulgaris. The objectives for this presentation are, first, I know there are a lot of non-dermatologists in the audience, so we'll review some of the basic clinical aspects of psoriasis vulgaris. And then we'll discuss how psoriasis disease severity is assessed. All of the biologic medications that we use are specifically indicated for patients with moderate to severe psoriasis vulgaris, and we will list those biologic agents, and finally I will describe my own treatment strategies for psoriasis patients who qualify for biologic therapy. And the outline for the presentation will mirror those objectives. So let's begin by talking a little bit about psoriasis. Psoriasis, as a lot of you know, is a very common, chronic, immune-mediated skin disease, and it affects upwards of 2 to 3% of the world's population. And psoriasis is one of the hallmark Th1, Th17 diseases and is characterized by overexpression of what are now well-known pro-inflammatory cytokines like TNF-alpha, IL-17, and IL-23. And it can sometimes be easy for healthcare workers to think of psoriasis as just a chronic skin rash that's maybe once in a while associated with joint inflammation. But those of us who treat patients with psoriasis and patients affected by psoriasis realize that its effects go far beyond the skin and the joints. And psoriasis is associated with a tremendous negative impact on patients' quality of life. It is well known to be associated with low self-esteem, stigmatization that affects personal and work relationships, and clinical depression in a significant percentage of these patients. And in addition, it creates a tremendous burden on our healthcare system with costs due to psoriasis in the United States alone totaling around $112 billion per year. Psoriasis clinically is a heterogeneous disease. It is not one single morphology of rash. There are different subtypes, phenotypes of psoriasis. And these different subtypes can have different effects on the patients. For example, plaque psoriasis. That is the most common subtype of psoriasis. It accounts for about 80 to 90% of all cases, and it is probably what most people visualize in their mind when they think about psoriasis. This is characterized by very well demarcated erythematous plaques that are covered in thick, whitish scale. And it preferentially involves extensor surfaces such as the elbows, the knees, and the scalp. Palmoplantar psoriasis is another common subtype, and this can come in the form of plaque-like psoriasis or a specific subtype known as palmoplantar pustulosis, where patients develop sterile pustules in these reddish-brown macules on the palms and soles. Both of these subtypes can occur in isolation or in association with psoriasis lesions on other areas of the body. Regardless, these subtypes are associated with significant pain and can be particularly disabling, as we use our palms and soles for essentially everything we do on a day-to-day basis. Inverse psoriasis in many ways is the opposite of plaque psoriasis. Instead of affecting extensor surfaces, it affects intertriginous areas, the axillary vaults, inframammary areas, the groin and the genital regions. Because those areas tend to be occluded and more moist, you don't get that thick overlying scale. But of course, patients who have these lesions in sensitive locations like the genital areas, this has a tremendous negative impact on their overall mental health. And finally, erythrodermic psoriasis. These are patients who are covered with at least 90% of their body surface area in psoriasis. So their faces, their ears, their scalp tend to be covered in psoriasis, and any interaction throughout the day can be difficult for them. Also important is that in the past decade, we have really begun to understand that psoriasis, especially in its moderate to severe forms, is a systemic inflammatory disease. And that systemic inflammation can have adverse effects on a wide variety of organ systems, and it is well known that psoriasis is associated with an increased risk of a number of important comorbid conditions that are often associated with inflammation. And this has changed how a lot of dermatologists think about treatment, that we really need to be more aggressive at treating patients with moderate to severe disease, because the ability to control systemic inflammation over long periods of time and perhaps change the degree of onset of some of these comorbid conditions most likely outweighs the adverse effects associated with systemic medications, including the biologics. So what are the biologic agents that we have available to us for treating psoriasis right now? There are 5 biologic agents that are currently FDA approved for psoriasis. 3 of these are TNF-alpha inhibitors, infliximab, etanercept, and adalimumab. The first of these to become available for psoriasis was etanercept in 2004. There is one IL-12/23 inhibitor available, ustekinumab. This is a monoclonal antibody that blocks the P40 subunit of IL-12 and IL-23, and it was approved in 2008. And finally, just several months ago, January 2015, secukinumab, which is one of several IL-17 inhibitors, was FDA approved for treating psoriasis. And these medications work very well to treat psoriasis. In the pivotal clinical trials leading to FDA approval for all of these medications, the primary outcome measure was PASI 75. Now, PASI has been mentioned a few times over the last 2 days. PASI is a clinical scoring tool that assesses disease severity in psoriasis, and it incorporates overall body surface area involvement and individual aspects of the skin lesions, degree of erythema, degree of thickness, degree of scaling, to give an overall severity score. PASI 75 implies that the patient has at least a 75% improvement in the baseline PASI score compared to at the time of reassessment about 12 to 16 weeks after the medication is initiated. And what you can see here is that all of these medications are effective at achieving that outcome measure in the majority of patients. The other thing that is important about this data is that the range of these patients who achieve that goal are similar. And that's important in our algorithms when we are initiating a biologic. Really, there is no one class of medication that stands out as being so much better than the other. And so we have all of these options to assess in individual patients. Some patients will achieve at least a PASI 90 or even a PASI 100, implying complete clearance of psoriasis. Again, in the biologic medications that have been available to us for some time, the percentages are similar. Not one agent stands out. There is excitement about the IL-17 inhibitors because in clinical trials, they seem to achieve these higher PASI outcomes in a higher percentage of patients, but real-world use of these medications is currently lacking. So let's talk about my treatment strategy. One of the most important parts of our algorithm is assessing disease severity, and this is not trivial. Classically, disease severity is assessed simply by looking at the amount of body surface area of psoriasis the patient has and assessing a severity and determining whether or not they qualify for systemic medication. And the National Psoriasis Foundation has published severity criteria in terms of body surface area. And just for your reference, you can think of the surface area of one of your palms as essentially being 1% body surface area. And with that, mild disease is defined as less than 3% body surface area involvement, moderate disease between 3 and 10%, and severe disease as greater than 10% body surface area involvement. But it is becoming recognized more and more by these large organizations, including the National Psoriasis Foundation, that we really need to take into account other aspects of disease to calculate an overall disease severity for our patients. For example, it is well known that psoriasis is associated with numerous adverse physical symptoms. In large survey studies, over 80% of patients experience skin pain. And you can imagine, especially patients who have palmoplantar psoriasis, where this can affect even their ability to do activities of daily living, their ability to perform tasks at work, and to participate in any recreational activity or exercise. The vast majority of patients experience pruritus, and in some large studies, over half of patients describe that they have difficulty sleeping because of the degree of pruritus associated with their psoriasis. Additionally, as we mentioned earlier, psoriasis can have tremendous negative psychological effects on patients, especially when sensitive anatomic locations like the face, the palms, the genital areas are affected. And that has nothing to do with body surface area involvement. You can have 2% body surface area involvement, but if one of those locations is affected, it can have a tremendous effect on your entire life. And again, in these large studies, almost a third of patients state that they cannot be as sexually active as they would like. The vast majority experience feelings of embarrassment, even helplessness. They have adverse interactions socially, even with their own family members, and up to 60% are thought to qualify for a diagnosis of clinical depression. So this is very important to know about your patients. And finally, it's becoming recognized more and more that we need to think about patients' perspectives of disease. What clinicians think is important in terms of contributing to disease severity may not necessarily be what patients think is important in contributing to disease severity. Dr. Kavanaugh mentioned a study called the MAP study yesterday. This was the largest multinational survey study ever done in psoriasis patients, over 3,500 psoriasis patients. And when they asked those patients to assess their own severity, 27% described their psoriasis as severe. And that included almost a quarter of patients who would otherwise be categorized as having mild disease, and almost 40% who would be categorized as moderate disease. So clearly, they think that aspects of disease other than body surface area is important in assessing disease severity. And when asked the most important factors contributing to disease severity, the number one answer in about 40% of patients was itching, and the number two answer was the location and the size of the individual skin lesions. Also, there have been some studies trying to determine how does psoriasis physically and mentally impact patients compared to other common significant chronic diseases like congestive heart failure, COPD, cancer, using quality of life scoring tools that can be used in those different diseases. And it's often found that psoriasis patients have worse quality of life scores in terms of both physical and mental aspects than patients with these other diseases that on paper many of us would consider to be more significant. So we have to take this all into account. And it's moving forward. Even at the GRAPPA meeting that Elaine and I were at last year, there were patients there who were weighing in on the discussions, including a patient that we shared together. So my algorithm first starts with assessing disease severity in these patients. And that includes, of course, looking at the amount of body surface area of psoriasis they have. Are there sensitive anatomic locations involved? And then the impact on the patient's quality of life in terms of both physical and psychologic impact. Now, the caveat to this, and something that we take very seriously, is whether or not the patient has psoriatic arthritis. We screen patients in my clinic at every single visit for possible symptoms suggestive of psoriatic arthritis and ensure they get evaluated if they are present. Because you cannot treat psoriatic arthritis with topical medications or phototherapy, and so regardless of what we want to think about disease severity in terms of everything we spoke about, if psoriatic arthritis is present, that immediately puts us in the systemic and biologic category, unless the patient's rheumatologist believes the disease is mild enough that those medications are not warranted. If the patient qualifies for a biologic medication, then I typically educate them about all the potential options that are available. As you saw with the PASI 75 data, not one class of medication stands out as being so much better than the others. I do usually reserve infliximab as a second-line agent, mainly because of the logistical problems for patients who work, going to an infusion center, the costs associated with that, the potential infusion reactions. Of course, we screen our patients for any diseases that may contraindicate one class of medications for the TNF-alpha inhibitors, specifically any personal or strong family history of demyelinating disease. And with the IL-17 inhibitors, in some clinical trials, patients with Crohn's disease have been seen to flare when given IL-17 inhibitors, so we will avoid those agents in those patients. And then I take into account patient preferences. These medications are mostly injected. We understand that a lot of patients have anxiety about giving themselves injections, at least if this is their first biologic medication, and have a lot of, or have some pain with the injections. And some patients initially may prefer to start on a medication that is infrequently dosed, something like ustekinumab, which is dosed every 12 weeks, instead of etanercept, which is an injection every 2 weeks, at least initially. And after our discussion, we initiate therapy. I add adjunct therapy to every single patient that I start on a biologic. Every single patient will be prescribed topical therapies, usually corticosteroids, sometimes other agents, with the rationale that patients can start using those medications immediately, and hopefully as the biologic medication takes effect and helps to resolve their psoriasis, they will need less and less of these topical medications. I occasionally will add methotrexate. I really like the combination of methotrexate and with a biologic. I think I use that combination a lot more than most dermatologists, and I think it is very underutilized in dermatology. As Dr. Strand taught us yesterday, addition of methotrexate has been shown to decrease the development of antibodies against some of these agents and to increase the serum levels of the medication. So I think it is an underutilized strategy. And then rarely we will add phototherapy or acitretin, which is a systemic retinoid agent that is well known to be effective in psoriasis. In terms of treat to target, the clinical trials utilized a primary outcome of PASI 75, but in reality, there are no clear guidelines in terms of treat to target for psoriasis vulgaris. That's probably due to a number of reasons. For one, I think this concept of treat to target is relatively new in chronic immune-mediated diseases. And also, psoriasis is not a scarring disease. There is not permanent damage to the skin. And that, in some ways, removes a sense of urgency to treat patients when they come in. A patient can have plaque psoriasis covering half their body for a decade. And if you put them on a medication that effectively will treat their disease, their skin will heal and look as if they never had any psoriasis at all. With that said, there is one paper, looks like you can't see it here. This was a European consensus group of about 20 dermatologists who did publish treat-to-target guidelines, and they suggest that if the patient achieves less than a PASI 50, then you need to modify treatment. If they're between PASI 50 and PASI 75, but they have quality of life assessments, that's the DLQI, that are high. This still has a significant impact on their quality of life. You need to modify. And if the patient achieves at least a PASI 75, then it's reasonable to continue. I don't necessarily agree with this, mainly because I don't think you're going to ever get dermatologists in the real world to perform PASI scores due to the time. But I do think we will see more about treat-to-target goals in psoriasis. It will have to incorporate quality of life in some way, and probably with time, as we understand the consequences of that systemic inflammation more, things along those lines as well. We see patients back between 3 and 4 months. We perform an objective assessment. How much improvement is there in the body surface area involvement? What about the sensitive anatomic locations? Is the disease resolved there? And then we subjectively assess the patient. I ask every one of my patients, are you happy? Regardless of what we think, are you happy with how well your disease is controlled right now? And ask them about their physical impairments and psychological impairments and if they're resolved. If there is partial but inadequate response after about 3 to 4 months, then we typically discuss 3 possible scenarios. Number 1, adding adjunct treatments. And the ones I usually consider are methotrexate, cyclosporin, and acitretin. Rarely we will think about phototherapy. Again, logistically, it's difficult for patients to get phototherapy. And typically, I will use doses of all of those systemic agents at lower than I would otherwise if they were being used as monotherapy. But we often get sufficient results by adding them. Another strategy is to reduce the time in between administering the medications. For example, adalimumab is dosed every other week, and we have had a lot of success in getting approval for weekly injections for ustekinumab instead of every 12 weeks, getting approval for every 8 or 9 weeks. And this we often have success in then adequately controlling the patient's disease. And finally, we will discuss switching biologic medications or classes of medications. And this is really after they do not have an inadequate response to the first agent, when I consider infliximab in general as a viable agent for those patients. On the other hand, if they have an inadequate response to therapy, if there is a discordant response between skin disease and joint disease in patients with psoriatic arthritis, or if they have an adverse effect that requires discontinuation of the medication, then we usually talk about either switching TNF-alpha inhibitors and possibly even adding adjunct therapies at that same time that we switch, or switching biologic classes and possibly adding adjunct therapies. And that's a somewhat simple regimen, simple algorithm, but I think it's simple because it works. We are very lucky. This strategy usually works in our patients with psoriasis. In terms of the future, there are 2 IL-17 inhibitors that have completed phase 3 trials. The data looks excellent. We expect that they will be FDA-approved. And additionally, at least 2 IL-23 inhibitors in early clinical trials that also have promising results. So in terms of being a dermatologist who treats psoriasis, there has really been never a better time in history where we get better efficacy, and it's more fun to see these patients come back happy. So thank you for your attention.